All right, welcome everybody. It is our October 1st Tuesday, and we're excited to talk about mental health parity. But before we begin, I do want to go through a few announcements of what's going on here at NAMI Johnson County. And we do have a new in-person connection recovery support group. And this group meets every Saturday at 2 p.m. at the Central Resource Library. I want to encourage people to come. It is free. It is for people who are living with a mental health condition and are seeking that peer connection. It's a great group of people right now. And so we're really excited about this new opportunity, and we just want to make sure everybody else knows about it. Our next announcement is that we have a mental health book club that'll be coming up on November 11th. They'll be discussing Girl Unmasked by Emily Cady and how uncovering my autism saved my life. So this is every other month on the second Monday of the month at Church of the Resurrection in Overland Park. And they choose a different book based on the topics that people are interested in. It is a great discussion and just a real good community that meets for this. So want to make sure that you all know you are invited, and please make sure to register if you're interested in coming. And of course, our NAMI in a Box that is out, we have just a few left for our community partners. And so if you know of anybody that needs a NAMI in the Box, this is a fantastic way to get all of the resources in offices, waiting rooms, and schools and doctors' offices around the whole city. So we just have a few left. So get it now or else miss your chance. Okay. And then our next First Tuesday is going to be probably on November 5th. I know we're talking that's election night, so we might have to move it around, but we're going to talk about veterans' mental health. And I'm really excited about this topic. I recently attended the Veterans Mental Health conference at Johnson County Community College and was really blown away at just what our veterans are living with. And in regards to mental health, like how we as a community can support them and understand just what they've been through as they've seen war. So that's going to be a fantastic opportunity in next month. So, and last but not least, please make sure to stay in touch. We do have our website up in our social media, but also probably the easiest way to find things as far as events and registration is through namijoco.org/calendar. That's the easiest way to find things on our website, and it's a great way to be able to connect and register with all of our events. So I'm going to go ahead and stop sharing my screen so that we can let our guests share their screen.
Okay, and before our guests start, this is Vicki, and I'm just happy for all of you that joined us tonight. As I was talking before we got started, it's kind of an eventful night. There's a lot going on in the world and just in general, there's a lot going on. So thank you for joining us. And I think this topic is going to be very interesting. It doesn't sound, it's never when you say insurance and government, I mean, sometimes there's a reaction to that, right? But I think Rob and Mary Lynn, who are with us tonight, I think they're going to break this down for us there's one of their three questions that they hope you will be able to answer tonight. I'm just going to read what they had presented to me. What are my rights under the Mental Health Parity Law? And what are some of the ways my employee's health plan may not be complying with the Mental Health Parity Law? And then who do I call if I suspect that my rights under the Mental Health Parity Law have been violated? So I think those are really some very interesting questions. So I'm looking forward to this. I will tell you, Rob Fitzgerald has worked at the Employee Benefit Security Administration, the EBSA, Kansas City Regional Office since January of 2015. Prior to working for the EBSA, Mr. Fitzgerald worked as an attorney in the private sector for over 21 years in Chicago and in the Kansas City area. He's received a Bachelor of Science degree in business management in 1987 from Tulane University in New Orleans. And Mr. Fitzgerald received both a Juris Doctorate in 1993 and a Master's of Law in 1998 from the John Marshall Law School in Chicago. And I'm going to let Mary Lynn Allman introduce herself because I did not get her bio before tonight. So she gets to tell you a little bit about herself. And Mr. Fitzgerald, you can add anything to what I've said so that we have your backgrounds. But we appreciate you both being here tonight, and we look forward to this. And we do encourage questions. I will tell you that we always encourage questions, and they would like to hear your questions. So please don't hesitate to do that. And I put in the chat a couple of websites that you might find interesting, or might give you some information, added information after tonight's presentation. So I will let the two of you take it over. So thank you for being here.
Rob, before I introduce myself, do you want to add anything to your introduction?
Probably important to know that I grew up on the north side of Chicago, so I'm a Cubs fan. That's all. The other thing I wanted to add, Vicki. That's it.
Pertinent information. Everybody had to know that. Hi, everyone. My name is Mary Lynn Almond. I am a benefits advisor. Rob is an investigator. So we both work for EBSA and work together to enforce the mental health parity laws along with a lot of other laws under ERISA. So tonight we're going to really hone in on mental health parity, and we do welcome questions as we go. We want this to be very conversational. It's not super formal. It's an evening, so we're outside of work hours. So let's have a little fun if we can. I don't want to bore you to death. And thank you for the introduction, Vicki. What you said is so true. People kind of glaze over when they hear insurance and government, but what you're going to hear tonight is very relevant information for your life, for your loved ones, for those that you assist and help. I think anybody and everybody should know about mental health parity and what it means. So, I have worked for EBSA for 5.5 years. Prior to that, I worked for the Railroad Retirement Board and the VA. So I'm also very passionate about um, veteran mental health. My husband's also a veteran. So I'm excited you guys are doing that event next month. That's so important. And so I love being in public service and I love interacting with people. I'm a graduate of Washburn and Topeka. So that is my alumni. But yeah, I'm excited to be here, and let's just dive into mental health parity. So can everyone see my screen?
Yes.
Okay. All right, so here we go. Our disclaimer. So it's important to know that in the context of this presentation, while the government speakers presenting, Rob and myself, are in official capacity, there's always the possibility that we might express a personal opinion, including in response to your questions, which may or may not comport with the official views of the agency. So take note. So I wanted to do a general introduction of EBSA because even if you know who we are, over time you may forget or mix us up with, other agencies out there. So the Employee Benefits Security Administration, our role is to protect the security of the retirement, health, and other workplace related benefits of American workers and their families. Our agency accomplishes this by developing effective regulations, assisting and educating workers, plan sponsors, fiduciaries, and service providers, and we vigorously enforce the laws. So, just to give you a general idea of how our office is set up, we are made up of benefits advisors and investigators. Benefits advisors provide individual assistance and information to plan participants, employers, plan officials, and service providers. We provide informal dispute resolution, conduct outreach education, which is what we're doing now, and that is what I do. So we're taking website inquiries, phone calls, we're going out in the public, trying to spread word about who we are and what we do. And we're doing a lot of one off informal resolution. Sometimes we take on plan wide concerns, but the plan wide, bigger scale stuff's happening on the investigative side. So, our investigators are conducting civil and criminal investigations and are involved in national and regional enforcement they might be investigating things like employee contributions, protecting benefit distributions, health enforcement, and contributory plan criminal project. Rob, is there anything you want to add on the investigative side that might give them a better picture of the
Sure.
day-to-day life in an
Sure.
investigator?
Yeah, so nobody ever wants me to call them because that means there's a problem. So Mary has a really hard job. She's the one who talks to actual, I shouldn't say real people, but people that have concerns and problem issues that Mary will try to help them to resolve voluntarily with their employer or the employer's human resources department, or if there's an insurance company that's helping the employer pay the health claims, for example, she'll work with them. If they can't get it resolved, then they send the case over to me, and then I have to go plan a visit to that employer and maybe the insurance service provider, the insurance company. But I was going to mention one quick thing, which was that like that contributory plan criminal project. You're probably wondering, do we actually have criminal investigations? Yes, we do. About 15% of our cases are criminal investigations. They're typically limited to, white collar crime, embezzlement, or theft, where someone at the employer is not, is taking money that belongs to, the employees or the health plan. So we'll just limit our discussion today to health plans. We won't talk about retirement plans, of course. But so what's important to know about the other thing I wanted to mention very briefly that Mary mentioned earlier was the word fiduciaries. And you might think, well, what the heck? What does that mean? What the heck is that? Well, it comes from the trust law. And so the employer sets up a health plan, and they're responsible. And the highest legal duty in the law is the fiduciary law. So it's like a trustee. Let's say that someone, it comes from the trust law. So if somebody was, God forbid, a child is orphaned, and then the parents, have some money to help raise the child, and someone is appointed to be a trustee. There's a trust fund set up, and so similarly, they have to really manage that money for the orphan, or if he has siblings, for the orphans. And so similarly, the employer here in a health plan context is a fiduciary and has a very high responsibility to take care of the employees and their family members that are covered by the health plan. So I just wanted to mention what fiduciaries are. It's just a big word that means someone is responsible for this health plan. So hopefully that helps.
That's really helpful. Thank you. And I'm glad you clarified what that word means, because it is a very legalese term that I don't think we use in our everyday lingo. All right. So, as I mentioned earlier, we have jurisdiction over ERISA Title I specifically. And ERISA is simply an acronym for Employee Retirement Income Security Act of 1974. And memorize that, because I'm going to quiz you at the end. Just kidding. So, since 1954, which 50 years ago this year, there have been so many changes, updates, amendments, the laws are ever changing and evolving. And mental health parity is an example of that. So, just to give you kind of an overview of what Title I includes, it includes reporting and disclosure. So, this is going to be the plan has to properly report not only to us annually through 5,500 filings, is what the form is. And usually, oftentimes, they'll use the help of service providers or people in the, financial or insurance world, like brokers, things like that, to help them with that process. Maybe, tax preparers, because everything's tied up in taxes. We know that. So they have to file annually with us so we can keep track of the general status of the plan and make sure they're doing everything they're supposed to be doing. And then also there's disclosure to the participants and beneficiaries that are in these plans on the health side and on the retirement side. So I'm not going to get super detailed into that, although that does play some part in mental health parity. We'll dive into how it relates later. But it's always important for people who are in a group health plan to be able to clearly know, read, understand what their coverage is and what it isn't. What are their appeal rights? Who do they contact in the plan? These general information things that are easy to take for granted until you have a need to know that information. And that's where these disclosure requirements play a major role. A big part of the calls that I'm taking daily are people who simply need documentation to confirm that what they're being told is true or not. And I always tell people it's not the Wild West. Employers, plan fiduciaries, they're not making things, they're not supposed to be making it up as they go along. There are rules they're supposed to be following, and a lot of those plan rules are supposed to be in these official plan documents. So We also have jurisdiction over Part 2, which would include participation and vesting. This is going to be more so on the retirement side. Funding, which would apply, I would say, more so to the retirement side as well. Although we have different types, as we know, of funded plans for insurance. Won't get too deep into that. Then we talk about fiduciary responsibility, as Rob mentioned, the role of the trustee, and who's administering the plan, making executive decisions. And then we have administration and enforcement. We have good old COBRA and good old HIPAA. People have heard of those. Those are memorable acronyms. By now, we know what it is. And hopefully, as well known and as recognizable as COBRA and HIPAA are to people when they hear it, the hope is that mental health parity will be right there with it in the not too distant future. At least that's my hope. I'm sure Rob would say the same. Rob, did you want to add
Yeah.
something?
Yeah, I was going to go back one slide real quick on the funding. You might think, well, what does funding have to do with any of this? So I'll just give you an example. So I have a case where, we'll choose hypothetical terms, an employer, a medium-sized employer had set up a health plan. And what they were supposed to do, they can either set up a separate trust fund, as I mentioned, separate legal entity, which has its own bank account. You take their money. Let's say the employees might give some money for their health insurance coverage, let's say 20% or whatever the case may be of the cost monthly. And if they say, well, I have my whole family, I don't want to have this insurance coverage, so I'm going to have to pay some money. And the employer is supposed to take that money in that fiduciary capacity and as a trustee and put that money aside and set it aside to make sure they're paying the claims, the health claims according to the health plan. And so what they might not do is take care of that money properly. I mentioned the criminal thing earlier, but it could just simply be this company might be going bankrupt, or let's just say they're having financial trouble. And so they don't necessarily put that money aside. So that's where the funding part can become important. And so that's usually an investigation level situation. But I just wanted to mention that it's not just the retirement plans that have to be funded properly, because, if you promise someone to have health insurance and you give them a plan document and say, you've got this coverage for medical, surgical, or mental health benefits, the money has to be there to pay those bills. When those medical providers give the service, the mental health provider provides service to you as an employee, you want to make sure that money's there. So what we do on the investigative side is we try to make sure that money's there. So hopefully that responds to the funding question, because you're probably saying, well, what's the funding question? So insurance is different, right? The insurance company has the risk and you pay a premium. So it's totally not what we're talking about here. We're talking about the employer setting up a plan to pay, and they sometimes pay it not out of a trust fund. Sometimes they pay it out of their general corporate assets, and hopefully that money is there. But I just wanted to mention that real quick, Mary.
No, that's
Mary
great.
Lynn, and Rob, this is Vicky. And just in the chat, Jennifer had a question about, and this was a slide or so ago, but I think it relates to this overall thing. Does this only apply for full-time employees?
This would apply to anyone who qualifies for the health benefits based on the rules of the plan. So usually that is going to be people who work so many hours to qualify to be enrolled in the group health plan. Yeah, so it would exclude potentially part-time or seasonal workers. It just kind of depends on what those rules are. And once again, that's information that should be in the plan document. Go ahead, Rob.
Right. And if you're working for an employer, whether you're participating in the health plan or not, you have a right to request a copy of that plan document. And there's also a summary page that you can get. We'll talk about the coverage, and there's all different types of information they really are required by law to give you. So if you're not sure, your employer will be required to provide you with that information. And then if you have a problem getting that information, you can call us and we'll make sure you get that information. But the other thing I want to mention too is sometimes people are unclear about it because maybe they're working part-time, or maybe let's say they're in a labor union or something like that. So you don't have to necessarily be working 40 hours a week. You could be working less than that. But like labor unions in particular, let's say you're a construction worker, you might work a job for full-time, more than 40 hours a week for, a couple months, and then you don't work for a few months. You still might have some eligibility and how the union set up the contract. So sometimes there's a contract for employment, sometimes there's not. Usually there's not, but I just wanted to mention that as well. So
that's great information.
Tricky. That's why you have to get that in writing. So you ask your employer, I want the information about if I'm eligible for the health plan, and they are required to give it to you by law.
Absolutely. Thank you. And thanks for the question, Jennifer. It was a great question. We welcome questions. So what does ERISA essentially cover in a nutshell? It's going to be pension plans, welfare plans. So this would include medical, dental, vision, short-term, long-term disability, sometimes life insurance. But it must be employer or an employee organization, as Rob mentioned, like a union is an example of that, common example. But they're going to be sponsored benefit plans. So essentially does not cover, we do not have jurisdiction over government or church plans. Government, specifically anyone employed through the public sector. So if a person is employed by local city or county government, state, or feds, that's not under us. Um, Sometimes there's, I think, some state jurisdiction over some of these plans, and I think sometimes there's no one that has jurisdiction over these plans. Rob, do you know more about
Well,
that?
so that's good. That's a good point. I'm glad you mentioned that, Mary. So so it can get a little tricky, but I was just up in Des Moines a week or so ago talking to with some people alongside the Iowa Department of Insurance person. And so basically between us and the state, if you're working anywhere and have health insurance, other than if it's a single plan for yourself only, say through the exchange, for example, that's one of the outliers. Or if you work for a church, for example, and even some church organizations, let's say a church sets up a hospital, let's say Advocate Healthcare, for example, or Advent, uh, or various other, hospitals can be really big employers, and they can be have really big health plans and lots of employees, so they can be subject to ERISA depending on. But that's where the key thing is. You always have to ask yourself, who would know if I'm covered by this health plan? And you request that document. It's in writing. They'll give it to you. Hopefully, they might email it to you, but you can print it off and read it, and it will tell you if it's covered by ERISA or not. It'll just tell you.
Yes.
So
It'll tell
that's
you if
what
it
I'm.
is or not. Yes, if there's any question, that's how we find out for sure. So some example, I think it's always good to understand, to give you a picture of things, what's not covered. So unfortunately, benefits we do not have jurisdiction over would be overtime, holiday, or premium pay, or bonuses, including sick leave, vacation pay, scholarship programs. So we get a lot of overlap in my department. We get a lot of calls that should be to the Wage and Hour Division of the U.S. Department of Labor. Their title kind of speaks for itself, wage and hour, and so they actually don't. Then they have jurisdiction over the Fair Labor Standards Act, I believe, is what it is, and so they're going to be the ones that you talk to about wages. But even some of this, I don't know that they even have jurisdiction over. So there are other, obviously, DOL sub-agencies that have jurisdiction over various labor laws. And so to hone in on welfare, I did want to quickly skim over just to give you guys an idea of what's going on, what type of inquiries are common, because these common ones are probably the ones that will most likely affect people that you know or yourself. This would be issues involving COBRA, which is eligibility. Am I eligible or am I not? Really, most people should be eligible for COBRA. There's only a couple disqualifying factors which don't commonly occur, such as being terminated for gross misconduct would be a reason you would be disqualified from COBRA, or if the company goes bankrupt and is no longer, or is dissolved, you could say, and no longer has a group health plan at all for even active employees. But outside of that, we are constantly helping people understand their COBRA rights, including election notices, costs for premiums, etc. And I think that most people at some point in their life, when they're in transition for one reason or another, may be eligible for COBRA as a dislocated worker. Sometimes people get laid off. Sometimes people choose to leave, retire, resign. All of those reasons would be a qualifying factor for COBRA. And we also help people commonly with group health plans that gets canceled for non-payment of premiums. This is a very unfortunate situation. Some would say a nightmare situation, especially if you have ongoing care for cancer, expensive surgeries, pregnancy, and then this happens in the midst of that. It can be very life altering when people think they have insurance and in fact they do not. and it's not their fault. They were paying the premiums, and their employer told them they had insurance, but they didn't after all because it got canceled because they weren't paying premiums. So those big plan-wide scale cases, they often get referred from us over to the investigative side. So Rob, if you want to speak a little more on that, go ahead.
Yeah, that's true. Everything you said is absolutely true, but I wanted to mention that, do not give up hope, because even if you're with a big employer and there's this huge problem, like Yellow Corporation, for example, a big company in the area, they went bankrupt, essentially went out of business, and there were a lot of employees outside of the union employees. So the non-union people worked in the office. There were a lot of people that worked in that office in Overland Park, and they had or somewhere in the metro, I think it was Overland Park. But the point is, they didn't know what they were going to do, right? Because some of them had health claims and they were worried about whether to get paid. And so that's where we come in and say, listen, you fiduciaries, you got to make sure you pay for this. So quite frankly, under ERISA, if those fiduciaries are responsible and they didn't fund the benefits in the plan, then they're personally responsible. So if they might be high net worth individuals, that might be CEO or CFO or whatever, we will make sure if there's money to be found to pay claims, we will find it. And I work with bankruptcy trustees all the time. Things go into bankruptcy, it's not the end of the world. Do not go. You call us and we will look into it. So Mary is absolutely right. Sometimes there's no money, but if there's a way to find it, we'll find it.
Absolutely. Yep. Exactly. And then another call that or inquiry that is common that we get or that we're looking at are unpaid medical claims, and that's a big part of even mental health parity. So having claims that are either not getting paid correctly or at all are getting stalled out. So that's a big issue. So this is just some general information. Health insurance is there to protect people, obviously, from possible financial loss, and it's to include all of these things. And health insurance essentially was developed as a way to share the risk, and so that's where, as Rob touched on earlier, you have different types of insurance plans that are available out there. You have level funded, self-funded, fully insured. These are all the types of plans you could say that exist where risk is shared differently. But as we touched on earlier, there are different types of insurance. We have private, which is what we're going to be dealing with what we have jurisdiction over. And this is going to include the employer sponsored insurance. And individually purchased insurance is going to be what you would think of like through the marketplace usually. Healthcare.gov is what it is. Then there's public insurance, of course, which includes Medicare, Medicaid, federal and state government employee plans, TRICARE, VA, etc. And essentially, insurance companies pick groups to insure and set limitations on coverage and negotiate with healthcare providers to discount their charges. And consumers end up being charged with premiums, deductibles, and copays, which we know that. And then this is some verbiage that is going to be used a little bit in our presentation, but most of these you're probably familiar with. They're pretty straightforward, pretty self-explanatory. So I'm going to kind of skim through that. So, and this is back to just the basics of private health insurance. So these employers sponsor plans providing benefits, and the insurers are selling them the policies, and the service providers are often administering all these happenings. So, in my day to day, I'm interacting with a lot of different types of people. I'm interacting, of course, with participants, and Rob's probably the same way. We're interacting with participants, we're interacting with third party administrators or service providers, as well as fiduciaries. So, all across the board, there's lots of hands in the pot, you could say, playing their role, and sometimes sorting out who does what is a big part of it. So employee organizations such as unions may also establish plans as well. Okay, let's switch gears.
Okay. Are we
Yeah,
switching
go
gears
ahead.
to me, or are we switching gears? Are you switching?
Oh, no, I'm just gonna start mental
Okay.
health parity.
Well,
I'll hand it off to you.
before we do, let me just jump in real quick.
Yeah, go
So,
ahead.
that booklet I was telling you about, that summary booklet, we call it the summary plan, the description of the summary plan description, or the SPD, sometimes we call it that in our office. That's just going to tell you, like, if you're not sure who's in charge, who's running the show, there's a page in there that says this person or this committee at the company is responsible, and that gives you their phone number, and it gives you their address, that sort of thing. So yeah, you might wonder like who's in charge, but that document must tell you. It has to be plain English. It can't be like complicated legalese. It has to be like this person, that person. Here's their phone number. Here's their office. Here's their address. So just, Mary's right. Sometimes it's hard to sort out who's responsible for what, but they're supposed to tell you this is who you call for questions. This is who's responsible for making
Yes,
sure you
and
get
I want to
paid.
just say too that
Mhm.
something we're commonly explaining to people when they're trying to sort out issues that are arising with their health insurance is it's always important to keep in mind that corresponding in writing is really the ideal way to go. Via email, obviously, is the quickest, fastest, most convenient way. And so I always throw that in there when I'm like, if you have a question about anything, when you're asking, because even the laws talks about it, if you request a plan document in writing, they have to give it to you within 30 days. But the big thing to notice is in writing. So verbally leaving someone a voicemail, asking someone in person, that's not going to cut it. So it's really good if you need information, have questions, want to request documentation to do it in writing. Okay, so
Yeah,
I'm going to do a brief
absolutely.
introduction. Oh, go
And
ahead.
I'm sorry, Mary. I'm really
Go ahead.
bad or good at interrupting people. I'm good at interrupting. So I wanted to mention about the union. So there's a big union in town, for example, that's in Kansas City, Kansas, I should say, the Boilermakers Union. And they're real, that's their international headquarters. They got lots of members throughout the country, actually in Canada, so it's international, right? But they have insurance for their employees. So a lot of people work for the union, but the last slide talked about union plans. So that could mean one of a number of things. So you might be an employee, or you might be married to an employee who works for a labor union, and you might wonder, like, what's up with the health plan? Like, who's responsible, the union or the employer or both? And sometimes it's both, and sometimes it's the union, but typically it's both. And so if you're not working for the union, if you're just working in a job, let's say you're working for a grocery store, you're working for Price Chopper, you're working for Hy-Vee or whatever the case may be, and there's a, United Food and Commercial Workers as your union, they would have negotiated for the health benefits with the employer. So it's kind of both. So I just wanted to quick throw that out there too. Sometimes that can be confusing. Like I said, who's in charge?
Yep, exactly. Thank you for clarifying that. Okay, so I'm going to do a brief introduction on mental health parity and what it is, a little bit of background, and then I will hand it over to Rob when we get more into the NQTL section, I think is where we're switching here. So
Oh, sure. Give me the hard part. No, do we want to show the video, or is that not going to happen?
we can. Yeah,
I don't know.
we no, we can
I queued
definitely
it
show.
up, but I just thought, if you want to do it here or after, I don't
Do
know.
you want to get that fired up after?
I
Let
have
me
it
do
here.
these
I don't
couple
know
slides.
if if I can work this computer. So what do I need to do? You need to give me control of the deal here.
Yeah, I'll stop sharing if you want to share that
Okay.
video real quick.
Okay. So I go down here to share, right? Share screen. Oh, host disabled, attendee screen sharing. Oh, I'm in trouble. Here, why don't I send it to you? Can I send it to you?
Yeah, send it over to me and I'll share it.
All right, I'll do that. I'll drop it in the chat maybe. Would that work?
Yeah.
Let's see here. Okay.
Rob, I just made you co-host, so you can
Oh,
share if you want to. Yeah.
Sharing. Screen. Share. Go. Come on, screen sharing. You're screen sharing. Okay, did you guys see that or not?
Yes, we can.
Okay, so here it is. Hopefully the audio will come through.
I can't hear anything.
Okay, not hearing it? Okay.
Mm-mm. Is your sound
See here.
turned up? Yeah, Amanda said she also can't hear it.
All right, let me put it through I have to change it to the computer audio, right? Or maybe I can just make it really loud so you can hear it. Okay, I'll try that. Okay. See if I can turn this up here. Oh. Hold on. This, okay.
Stable volume is off. Does that make a
Is that
difference?
maybe? Oh, I thought this would be easy. Okay, let's see. How do I use that?
Is it ever? That's not okay. Oh, it says mute. Yeah, I'm still not hearing it.
Okay, well, I will try to put it in the chat so that maybe.
Yeah, everybody can just watch it later. It's only 48 seconds.
That's right. Okay.
I'll try to make my little quip about it as interesting as
go.
the video.
We can watch it, or you can watch it, before you go to bed tonight. That'd be great.
All right. Thanks for trying, Rob. A for effort. All right. Here we go. So, the introduction to federal mental health parity. Basically, this law came about in response to an inconsistency in insurance coverage. And it generally refers to the concept that promised mental health and substance use disorder benefits should be covered without special barriers and roadblocks to access that do not apply to medical surgical benefits. There are two major mental health parity laws at the federal level. They include the Mental Health Parity Act of 1996 and the Paul Wellstone and Pete Domenici, of course, that's a hard name, Mental Health Parity and Addiction Equity Act of 2008. So that's a very surface level overview, and there's a lot more to it than that, and we'll get into that as we move on. So let me go ahead and move over to the next slide. Essentially, and I'm going to call it MAPIA, is what we call it. It's just easier than saying the whole thing. MAPIA requires that group health plans and group health insurance issuers must provide mental health and substance use disorder benefits at parity, aka in a similar way with medical surgical benefits. So, mental health and substance use disorder benefits could cover mental health, substance use disorders, behavioral health, emotional and nervous disorders, and addiction. So, there's a wide range of things that are, types of care, treatment included in what we would consider mental health and substance use disorder benefits. So, who is subject to these laws? Employer based health plans and health insurance issuers offering health insurance coverage for medical, surgical, and mental health substance use disorder benefits. So, it should be noted, and it's insinuated with that bullet point. But as of now, anyway, group health plans are actually not required to offer mental health benefits. But if they do, they have to be in parity with the med surge benefits. Now, I would say it's kind of common knowledge for most employers offering a plan that they know that there is a desire and you could say a demand for mental health care to be as part of their plan. So, but it doesn't mean that they're required to. So, just want to throw that out there and say a lot of them do, but they're not required to. And then these laws also apply to private employer plans that have 51 or more workers. Also, most small employer plans and health insurance coverage sold to individuals, for example, in the marketplace. Oh, there's that little, I just noticed that. What I just said at the bottom. So, what protections does federal mental health parity provide? We're going to try to make this a little bit more clear for you. It basically ensures that the financial requirements and the treatment limitations are to be equal or comparable to the requirements or limitations applied to medical surgical benefits. So, financial requirements in a nutshell would include copays, deductibles, coinsurance, and out of pocket maximum. Treatment limitations would include the visit day limits and duration of treatment. So, we're going to start with the financial requirements and treatment limitations. Now, when we're looking at these comparisons, you could say, we are classifying them in six classifications, and they're fairly straightforward and I would say pretty common sense, but it's important to understand these classifications. You have inpatient, in network, out of patient, out of network, inpatient, out of network, emergency care, outpatient in-network, and prescription drugs. And so if a plan provides mental health and substance use disorder benefits in any classification, then those mental health substance use disorder benefits must be provided in every classification in which the medical surgical benefits are provided. When you really get into the nitty gritty, you could say, of all of this, the comparison, it can get kind of tricky. And I would say we're in the process of navigating that. And maybe Rob can speak more to that when he gets more into his section of the presentation. Okay. And I'm going to, let's see here. Okay. This is my last slide, Rob, if you want to get yourself queued up. So, in regards to mental health and substance use disorder benefits, a plan may not impose a financial requirement, such as a copayment, or a treatment limitation, such as how many visits your plan will pay for, that is more restrictive than the predominant financial requirement or treatment limitation of that type that is applied to substantially all medical surgical benefits in the same classification. So, we have a really great example right here. For example, Josh is insured by X Health Plan. X Health Plan has the following co-payments, aka a financial requirement for psychiatric visits and primary care provider visits. The psychiatrist costs him $75 as a copay, and the PCP costs him $20 as a copay. Is that comparable or in parity? No, it's not. And so that's fairly straightforward and easy to identify, right? It's cut and dry. And when you're getting to the treatment limitation side of things, it may not be so clear. So, what we're going to say here is this is likely impermissible. We may need to do more digging into it, but at least on the surface, it does not appear to be permissible. All right, I'm going to go ahead and let you take over, Rob.
Okay. So I have the super fun part. So this is the catchiest acronym since COBRA. I mean, everyone knows COBRA because, you lose your job or whatever, and you might need to continue your health insurance, although you have to pay for it. You might want to do it, especially if you got a lot of bills, right? So COBRA is like a cool acronym. I mean, it was in, Karate Kid. I mean, there was Cobra Kai. I mean, obviously everybody knows what COBRA. Everyone knows what a COBRA is, right? But NQTL, that is a horrible acronym. I mean, that doesn't. How do you even say that with a straight face? NQ. What is it? What are they talking about? What are we talking about? We're talking about a limit that's placed on mental health benefits. It's not something that you can quantify. You can't. It's like a numerical limitation, like we said on the prior slide. If someone says, "Hey, you have medical benefits and you can go to the doctor as many times of the year as you want to go to the doctor because you broke your leg or you got sick, you got the flu or whatever, but you can't then plan can't turn around and say, well, we're going to limit the mental health visits to 10. It's quantifiable. It's a number, right? It's quantifiable. But there could be other ways they could try to limit your access to mental health. So that's a non-quantitative treatment limitation is all about. So we'll go with NQTL because we have to, because that's what they call it. So it's a limitation on the scope or the duration of benefits. So again, the duration part, arguably that's quantitative, but really what they might say is you can get mental health treatment for a specific mental illness, but only, for 6 months or something like that. And so that's not permitted, right? So here it's generally not expressed numerically. I mentioned that, and the plan may impose this on the mental health or substance use disorder benefits unless there's some other justification for it. I'm going to read all this slide. It's a waste of time. Essentially, what they're saying is, they're trying to find a way to limit your mental health benefits, and we're not going to let them do that unless they have a really, really good reason. So it talks here about medical, evidence and that sort of a thing. So let's move. I don't know. Can you switch to the next slide, Mary? I'm not sure if I can do that here. I'm better with talking to people and talking about stuff than I am with computers. My wife was so excited when I got my first smartphone. She's like, "You're gonna love it. It's just like a computer." And I'm like, I hate computers. Why would I want to carry a computer around with me all day, every day? It's horrible. Anyway, what are some examples? Okay, this might help explain what this is talking about. So we all understand the quantitative treatment limitations. You can't say, you can only go to the mental health provider 10 times a year or 20 times a year. But what are some examples? Okay. Medical management standards that limit or exclude benefits based on medical necessity. So medical necessity may be something you've heard of before. Maybe you had a medical condition or a mental health condition, and some doctor or therapist said, "Hey, I have this new idea that might work," and it may be something like a new approach, like it's experimental. It's actually it's an investigative thing. They're trying to see if it will work. The plan might limit that, but we can't make sure that they're not putting the limitations on the mental health the same. It has to be the same as the medical. So there may be some experimental medical treatment, and there may be some experimental mental health treatment. But if you look at, they have to be compared. We have to compare them. So it's kind of hard to give this presentation and give you really specific examples, because every example is going to be different, especially if we're talking about, hey, I got a new way of treating this, and we're going to call it experimental, so we're not going to cover it. Well, the best example I can think of is a lot of autism therapy is a very important area of mental health where sometimes autism treatment can take a long period of time, and then there might be some established treatment methods that really maybe started out experimental a couple of years, maybe several years ago, and now they're really not experimental. We know that they work, so we're gonna say that they can't. Your health plan can't put that label on there. Oh, well, this is experimental. We're not going to pay for this. It's too expensive. If they're not doing that to medical benefits, they can't do it to mental health benefits. That's the bottom line here. So some things that they do also do, like the second box on the left side there, pre-authorization or review standards. So sometimes it used to be a big thing in medical insurance. You used to have to go get pre-authorization to get some expensive tests. Now you can go in and get an MRI for like $40. I mean, it used to be like $400 or $4,000 when it first came out. So, well, we're going to pre-authorize and make sure, that you should get this medical treatment. So sometimes they will not do that on the medical side, but they'll put it on the mental health benefits, and we'll tell them, no, you cannot do that. It has to be a parity or roughly, equivalent to the medical benefits. Let's the next box here. It says standards for provider admissions. So to a network. So this is a big issue. Let's see, we got some stuff in the chat. Were you coming in to talk about that, Vicki?
I was, just that we had a question in the chat that I thought was, it's not really a question, it's a statement.
Yeah.
I've gotten an answer from insurance that this is a specialist, and thus the extra copay.
Yes, very good point. So we might be getting to that point. Let's see, standards for that. Well, that might be under reimbursement rates, right? So this box I was just about to go into, I'll cover that right now. So yes, so obviously, if I have some sort of I need to go see a specialist on a medical case. So let's say, for example, a dermatologist. So I've had I have a dermatologist. I have him on speed dial. I go to see him once a year, and he checks me out because I'm very fair skinned. So played a lot of soccer when I was a kid, got a lot of sun. Now I'm paying for that, right? So the point is, he's a specialist, right? So he had some extra medical training, so his rates of his cost is higher, right? So it used to be you had to pay extra for the specialist, right? So similarly, when you look at a mental health specialist, like autism might be a good example. For example, someone might say, I'm a mental health provider, but this person might say, well, I have special expertise in autism. So what we're going to do in the parity comparison of the medical benefits to the mental health benefits under the plan is we're going to look at this here. This box in the lower left corner says standards for provider admission to participate in the network, including reimbursement rates. So that's talking about in or out of network. So it's not the same. I'm going to put that to the side and pretend I didn't say that. So talking about a medical doctor or a specialist, a mental health provider, and a mental health provider specialist. So that is sort of a fact specific thing we'd have to investigate. Mary, I don't know if you have any thoughts. I mean, essentially, I guess my question would be, if you think that that's wrong, I guess you would want what? Mary, you want to jump in?
Yes, call us. Yeah, we would want to ask more questions. We'd go into a fact-finding stage. On the outset, we can't outright say, oh, that's wrong, that's a violation of mental health parity necessarily. We would need to see, we would go to the plan basically and put the onus on them and say, okay, how did you come up with paying this amount for this specialist on the Sorry,
Oh.
just muted myself on accident. So how did you come up with this? And then we would basically say, do we agree? Do we not agree? And we're going to look at the plan document too, because
Mhm.
one thing he's going to get into is it's not just about what they have in writing, but it's about what they're doing in practice as well.
Right, 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 exactly. So when it comes to your question, Jennifer, okay, I've got an answer from insurance. This is a specialist, and this was some extra, and I'm going to scroll down here. Oh, extra copay, yes. So the plan is no doubt written up that if it's a specialist, there's an extra copay, like you said. So it's unfortunately an investigative question, like, why is it a specialty? Is there something else in the plan document that addresses this type of treatment, for example? That might be a clue to answering that question. But it's similar, quite frankly, to this box I was just starting to talk about, the standards for provider admission to participant in a network. So everyone's familiar with the in-network, out-of-network, thing. The health insurance company or usually a health insurance company will go out and try to negotiate with the medical provider, say, hey, we got these big health plans and we want to send them your way. We want you to be in the network. You give them a break on the cost, and we will send you all these people and put you in the network. And so it'll be great. Well, the problem with mental health, what we're finding these days in 2024, is that mental health providers are in high demand, and they don't really need to negotiate. They don't need to go looking for clients, right? Typically, patients or clients are knocking down their doors saying, I need mental health treatment. All the things that have been happening recently, whether it's COVID or whatever the case may be, they're not so inclined to sign up to be a network provider and give a discount to anybody. So sometimes it's difficult, and unfortunately, for purposes of this presentation, it's difficult to give specific pat answers to some of these questions because like as Mary just said, it depends on what they're actually. The plan might say something. The plan booklet might say, the network. The plan might even represent we have lots of mental health providers in network, and so you get a better deal. But in reality, do they really have enough or sufficient number of mental health providers in network or not? Or what are they doing to try to get them in network? That's always a big network adequacy is a huge issue right now that we're still kind of working out and trying to hold them accountable. By them, I mean the employers, the sponsors of the health plans, and the insurance companies, because it's hard to find mental health providers that will agree to be in the network. Some of the other things here, it's easier to talk about step therapy or fail first policies. That's where they'll put additional requirements on mental health benefits or addiction treatment as well, where they'll say, well, we don't do this for medical conditions, but we're going to say for mental health conditions or addiction treatment, substance use treatment, that sorry, they changed the term from substance abuse to substance use disorder, but it's using substances that can harm your health. So they'll say, well, we think you should try this other method first, because it's cheaper. Let's face it, it's cheaper for the insurance company or for the health plan. And they just can't do that. If they're not doing that to the medical benefits, they can't do that to the mental health or addiction treatment benefits as well. And then here, coverage restrictions, the last box in the lower right corner, coverage restrictions based on geographical location, facility, type of facility, provider specialty, which goes to Jennifer's question, and other criteria that limit the scope or duration. So, again, we're looking for parity, Jennifer. So if you have a specific situation in mental health treatment or addiction treatment that is saying, this is a specialist, we're going to look at the specialists on the medical side as well and do a comparison and try to see if they are in fact treating it similarly to the medical treatment that's offered. I have to apologize.
Rob,
my
this
dog
is Vicki again.
in. Go ahead.
I hate to interrupt you. I'm sorry. I'm just wondering, can you think of a specific example just of where in the mental health parity case that the insured won the case? Can you think of an example that something they presented that something was changed or they got what they needed?
Yes. So what I'm going to talk about. So we had another benefit advisor do a presentation this year, and she talked about some specific examples. So I'm just going to go steal some of her some of her examples of things that she did, because this is stuff that actually happened in the past, and that it's something that was that I can say definitely did happen. Our agency was able to help some people. So she's talking in here. I'm just reading through her notes from her interview that she gave. I'm just trying to find it here.
I was going to say they're on the second page.
Yeah. Oh, there's an example. Okay.
Yeah, there's an example on the ABA therapy. Is that the one you were going to share? Yeah, go ahead.
Sure, go ahead. That's one of them. Go right ahead. Can you read
Okay,
that?
I was just going to say,
Sure.
so one example is we did, EBSA investigated a large service provider that excluded coverage for applied behavioral analysis, ABA therapy for treatment of autism in hundreds of self-insured plans. So this was pretty large scale. And EBSA's investigation resulted in 3 plans removing the exclusion for ABA therapy and offering coverage for that benefit moving forward, which ended up affecting more than 18,000 participants and their beneficiaries. So that's just a concrete example. And this is from May of 2023. So this is well over a year ago, a year and a half ago now. So there are more examples. We have to be very cautious about giving examples because, of course, we can't name specific parties and things. We try to stay away from that. But Rob, is there anything you want to add to that too?
Yeah. So some of the examples that our colleague talked about was this one. I think it's not very nice and generic, right? But I think it would apply, and give an illustration of what some of the things that we're able to do for people. So here it says a mother could not find an in-network hospital to provide mental health treatment for her daughter. So again, when I just talked about that, she's like, hey, I can't find an in-network mental health provider. And in this case, it had to be inpatient hospital. So it must have been a pretty expensive treatment that she was seeking for her daughter. So the mother was forced to seek treatment at an out-of-network facility, so obviously it's going to be more expensive for her, right? Resulting in her having to take out a second mortgage on her house, just to pay for these medical bills, her portion of the out-of-network treatment for her daughter. The EBSA was able to help by getting an exception under the mental health benefits of the plan, which ultimately reimbursed her for over $200,000. So the difference between in-network and out-of-network is no joke. $200,000, big money, right? And she was able to pay back and pay off that mortgage that she had been forced to take out. So that's an example of how much money we're talking about. Sometimes the impact of these limitations, these non-quantitative treatment limitations, like the out-of-network, like no mental health providers in the network within the area, for example, within the geographic area, can have a huge impact. Another example that our colleague mentioned at her presentation was that we investigated a health plan that had mental health benefits, and it excluded a specific therapy treatment for autism. And the plan ultimately was required to revise the plan benefits and reprocess over 1,100 claims, so 1,100 treatments for autism, totaling $631,000. So that's over 1,100 people. But to get you an idea of the magnitude of some of the impact some of this enforcement of this law can have in real dollars for real people, right? It's 1,100 people that were benefited from that. Now, another one, there's just 4 or 5 examples here. I'll just give another good example, I think, that highlights what we're talking about. So a health plan denied a claim for residential treatment for substance use disorder. So this patient must have needed to be in a residential treatment facility for substance use disorder. And the EBSA investigation resulted in the plan changing its terms to include residential treatment for mental health and substance use disorder. So again, it probably said something like, hey, we're going to cover, if someone needs to be in the hospital or needs to be in a residential, situation, staying at the hospital for a medical condition, then they didn't have a limitation on that, but they did have a limitation on the mental health or substance use. So here, the affected participant had a claim of over almost $57,000 that was denied. But after the plan updated the policy, they paid the claim. So these are some examples of real-world examples of things that happened. Again, we're taking out the names and stuff and that kind of details, but you get the idea that this is something that we can really help in a situation where it's really not following the law, where we can really get, these things worked out to the benefit of these participants and their family members.
Thank you. That's helpful. Those were helpful. Thank you very much.
That's something I was holding back in reserve just in case we need it, because I'm sure at some point you're going to get tired of hearing me talk. And you see, Vicki, how hard it is to interrupt me. See, it takes a lot of practice to be a good interrupter like me. I can help you with that. Feel free to just jump in there and say, okay.
Well, I just like the examples because it gives me hope. It gives me hope to say, hey, you know what? You really can call and make a difference in an individual or family's life. So
that's the thing that I wanted to say very, very briefly before we go back to the super exciting slides we were going over. But, Mary and the people that, when I wasn't joking earlier, they really have the harder job than I do. I mean, I get to go out there and kick some butt and take some names, right? But Mary, she's talking to people that are going through something potentially, life altering, some horrible situation. And now they don't have coverage for their mental health. They're trying to get treatment for themselves or their child or their spouse. And Mary, and the rest of us, we care, we want to help, and we will do everything we can to help. And we are everyone listening to me probably is in the Kansas City regional, area. There's 10 regions in the country, but we consistently have Mary and her colleagues are the best in the country, the best of the best. I mean, they recover so much money for so many people, because they just love people and want to help people.
And I can give a quick example of a case I had open, and this actually ended up not being mental health parity. It was part of my line of questioning to the employer, but it ended up actually being really more just a bad communication between the facility and the insurance carrier, and the insurance carrier moving really slowly. But it did involve mental health care. I had a lady call in on her adopted son who was getting ready to turn 18 or 19. I think he was 18 or 19, and he was going to begin to have rights to take himself out of treatment. But he also had a court order that he had to be in a very specialized type of mental health facility. There were only like 4 in the country because it was sexual based rehabilitation. So it was very, very specific to the type of mental health treatment that he needed and that he was court ordered. And he'd already been in a facility for 9 months. Well, when her new plan year started in January of that year, the company, really out of her control, changed insurance companies from one to another. That new insurance company said, we're not paying for this treatment. I think they thought this is too expensive. So she had like a 3-week grace period. She had to get this figured out and get them to approve him to stay, or else he was going to literally leave. And then he was going to be old enough to tell her, screw you, essentially, I'm not going back. And he needed the treatment. So this was very, very, like I said, life altering for this woman's life, for her son's life. And it was like, what we had to do was we went to the employer and we said, do you know this is happening to your employee? Get on your insurance carrier, get them to move this along. If this is covered under your plan, get this approved. So like I said, this wasn't necessarily mental health parity, because it wasn't a question of, are they not offering benefits? It was, are you going to get this approved timely, quickly, to keep him in the facility? So we get mental health related calls a lot. Let's just put it that way. Are they always mental health parity? No. But I tell you that, Vicki, because you're like, I want to know, do we have hope? Yeah, absolutely. On the ground, it is really helping people. And I'm only one of, like he said, 10 in our office. So that's only one story amongst many of the kind of calls and cases we're
And
getting.
Mary and Rob, this is Jennifer. If I could just ask, because I co-facilitate our one of our support groups, and you may be getting to this later in your presentation, but we often get asked, what do I do? So do they appeal the insurance company first in writing? Could they call you? I mean, when do they call you? It's good to hear something about 3 weeks time, because I personally have had some issues with some medical things, not mental health, that take almost 2.5 years to rectify.
Yeah.
And I didn't call ERSA, but anyways, that would be some good advice. We get often asked questions.
I always tell people early on in the process, get the employer HR benefits department in the loop of what's going on. Ask for them to get directly involved with, kind of the oversight to the insurance carrier to potentially expedite the request, whether it's a predetermination or pre-authorization, or it's on a post-service claim and you're in collections and you're freaking out. I mean, it doesn't matter what the scenario is. The employer kind of putting the fire under the insurance carrier essentially is an important part. Yes, their legal right to appeal, as summarized in the plan documents, extremely important to exercise that right. I tell people it doesn't hurt to exercise your right to appeal alongside talking to us, alongside talking to the employer, as long as you know that you do have in some limitations in how many appeals you can file. So be very careful and intentional in what you're including in any appeal. You want to make sure it's thorough. And I have to tell people all the time, and you may, Jennifer, too, if you've had some experience with this, is they don't want to hear your sob story. As important as that sob story is to you, and I'm not telling people to not share their testimony of how this has affected their life. They're looking at cold hard facts. So you want to quote that plan document, what is supposed to be covered under the plan. You want to reference the medical notes and tie it back to the plan document. You want to talk about directly attacking any reasons for denial if they have denied. And that's why a big part of what we're doing is just like pulling information. It's like pulling teeth, but pulling information out of the insurance carrier. Okay, so you denied this, but you gave us a very very vague reason as to why you denied it. We want the medical protocol, policies, internal guidelines that you're relying on to make that decision, to claim that this is not medically necessary or to claim this is experimental or investigative. We're just basically trying to pull information and then appropriately responding to that, once again, in a formal capacity in writing. And oftentimes there are cases in which an urgent appeal would be acceptable, in which there has to be that 72-hour claims turnaround time. And Rob, what would you like to add to that? I know you're just ready to jump in.
Can you, Mary, can you switch that to slide 18, because this talks
Yeah.
about this, Jennifer. So I could go through the next couple slides. It's 8:08. I don't want to go through the next couple slides because they're very complicated and unnecessarily complicated. I want to answer your questions. So if you skip on down, you're skipping down there to 18. It should be the one with the chart with the blue letters. Keep going down. Get out of that. Oh wait. Oh, they're all. Oh, they've been. Okay. So it's.
I think it was back here.
There it is. There it is. That one. Whatever that number is. That's it. So for Jennifer, so this is. It says, what to do if you suspect that your health plan has wrongfully denied your mental health or substance use claim. Okay. 1, call your health plan to get more information. As Mary was saying, let's get everything in writing. First of all, the bill. What bill did you get, health plan administrator person, from the mental health provider? What'd you get? Let me see the bill. Next, EOB stands for explanation of benefits. So I want to see the written response to the mental health provider and to me, as the patient or the patient's family member or legal guardian. I want to see that document, those 2 written documents there. You got a written bill and you got a written explanation of benefits. There's a lot of information there we do need to talk about that. You can leave that up to Mary and the other experts to handle. And the last point, your health plan summary. I mentioned this earlier, the summary plan description or the summary of benefits and coverage. You want them both. Okay. The summary benefits coverage is fine, but you really want the full plan. You want the whole smorgasbord of benefits. So then you got those 3 written documents that Mary was talking about. Then in step 2, file that internal appeal regarding your denied claim. So there's going to be a process in that summary plan description that says you have a right to appeal a denied claim. Here's what you need to do. Call this person, send it to this address, or email it to this place. So call your health plan. It says here, can ask what information they need to include in your internal appeal. So they'll say, we need this, we need that, and whatever. Maybe they want some other documentation or whatever. You give that to them in your appeal. The internal appeal should be submitted in writing. So you, like Mary said, put it in writing. And then it doesn't have to be like a legal document. It's just going to be a letter from you or an email saying, hey, this is what happened. I don't think you should deny my claim. And then you must get a response within 60 days. So unfortunately, it can be a long time, but at least it's there's a deadline. And step 3, if you're still not happy because they say, well, we're denying it anyway because A, B, C, D, F, whatever reason, request an external review. It's probably going to be available to you in the plan document. It'll say that the next step after denial of appeal would be an external review. So someone else will review the claim and the denial and the reasons, all the written documentation. Pursue this or something. Okay, so Your final internal appeal determination should have information on how to request. Again, it's in that summary plan description. And you must request this external review no later than 4 months after you get it. You'll do it within 4 months, I'm sure. You weren't going to wait that long. Then the external reviewer's decision to overturn will be made in 45 days. So there's a limit. There's an outside limit. So if you get it done right away, we're talking about 60, maybe 120 days. We're talking about 4 months. I'm not saying it's not a long time, but at
And
least
if it's
there's
a
a limit.
life-threatening condition,
If it's urgent,
then it
yes.
can be urgent. Yeah. And that can be argued in a lot of mental health cases if
Right,
there's
right.
a concern,
Absolutely.
of course, with
Right.
suicide or things like homicide,
Mhm.
things like
Yeah.
that could
Well, and
occur
that's
as
what
We
I
have
well.
those
I was
timeframes,
bringing
for
up
sure.
is usually we have a very situation with an involuntary hold for 72 hours. And
Ah,
so we have a lot of this is too long. It's like your example of the person having to get a mortgage on their home.
right, right,
And
right, right.
so
So,
so
right.
the
So the
loved one
urgent
needed
claims
to
are totally
be,
different. Yeah.
had to be in an urgent situation.
Mhm.
And that's what we hear a lot. So this
Sure, sure.
is still timely. So what I'm hearing though is you need to go through your own plan first,
Right,
go through that 4-month period, and then if that isn't satisfactory, then you would contact your department.
right. So you
Okay.
brought up basically like the exception to the rule. This is the general case, right? Let's just say
Right.
it's not a life-threatening situation. But yes, so a long time ago, in a galaxy far away, there was a health claims regulation, and I'm making a joke out of it because it really was a long time ago. And they laid out all this stuff in excruciating detail, Jennifer. Like, okay, urgent claims, this is compressed deadlines, shorter time frames. So that's sort of beyond the scope of this presentation. But that's something when I got out of law school back in the early '90s that I immediately read that front to back. It's a long regulation, right? And it's still pretty much the same as it was back then. But and it applies to any medical, not just mental health. It can be any medical claim. But the claims regulation has been all the insurance companies pretty much they know what they're supposed to do, and there are compressed time frames, like you said, for urgent claims or life-threatening situations. Unfortunately, I can't give you chapter and verse on that in this presentation. If you all were working for insurance companies, you might get into the nitty-gritty, as Mary said. But yes, the answer I guess we would be giving you is that because your employer set up this plan, maybe the insurance company helped them, but they set up the plan and it has all these rules about denials and appeals, et cetera, et cetera. Unfortunately, you kind of have to go through that process. But yes, if it is an urgent situation, as Mary said, it's going to be quicker than this. This is sort of the general guideline.
And speaking from experience, I can honestly say that looping in that employer HR benefits department early on is certainly effective in a lot of cases. That is one place where, and it sounded really cynical when I said it earlier, sob story. That's not the right verbiage. These are legitimate concerns, especially when it comes to mental health and certain conditions. So if the person's comfortable sharing that information of what could be going on with themselves or the beneficiary and certain denials or things that are happening, and they want to share that with their employer HR benefits, I have seen that move things along more effectively and oftentimes have a more positive outcome as far as approvals through insurance carriers. But I always tell people from the get-go, just because you get the employer involved and try to get them on your side essentially doesn't mean that it's going to get the desired outcome you want, but it probably more than likely will improve your chances. Does that make sense?
Right, because the employer doesn't necessarily know what the insurance people are doing over here, right? So you say I'm one of your employees, or it's my family member or whatever. They should care. They should want to help you. But Mary, can you flip to the next slide? There's a link in
Yeah.
here that talks about what to do if you suspect, and then you can learn more about filing claim, external review, et cetera, through this link. So can we somehow drop this in the chat, Mary, or I don't know,
Yeah.
Vicky, if we can, but our
We can
website
always
is
share these
actually,
slides as well. I'm happy to share our entire slideshow.
yeah, our we'll get that over to Joko Nami so that you guys can get it, because there's so much helpful information in here, and yes, it depends on your specific situation. And Jennifer, you have very specific questions, and we welcome those, but unfortunately, you kind of have to go through and kind of look at, like, this would be the best place to start.
Yeah. And that is just really that's just helpful in generics to say,
Right.
we all get it. And a lot of our loved ones don't have full-time jobs anyways.
Totally.
So,
Yeah.
after they reach 18, but for a
Mhm.
younger caregiver, there's a little bit more flexibility, but those of us that have older individuals,
Mhm.
they're not, a lot of times they aren't working full-time, or they are under a Medicare or a Medicaid plan or
Medicaid.
SSI,
Yeah.
doesn't, yeah. So,
Right.
but I do get those general questions, so I
Mhm.
appreciate, thank you for spending
Yeah.
that,
Yeah.
it's been an
Oh, absolutely.
educational
That's what we're
discussion.
here for.
Thank you.
We want to make sure it's relevant for you guys. I believe me, I could talk and you'd all be fast asleep by now if you just let me keep talking. But
But
We do
my wife,
appreciate,
we have the vice presidential debate to do that tonight.
my wife would always say, if one of the kids couldn't sleep, now my youngest is 22, but back, 20 years ago, she'd say, "Oh, go read some of those tax regulations to the kids and help them fall asleep." She always joked, at the cocktail parties, as long as my dream to be married to a tax attorney. I'd say, "Ha, what is my dream to be married to a patent attorney?" Because that's what she.
Yeah.
well, your
She's retired.
willingness to share the slides are helpul because
Yes.
we do
Yes.
appreciate your willingness
We're
to share.
happy to do that. Yeah.
And there
Yeah.
are links in there so people can just click and right up in there.
Yeah.
And
So
the
are
next
we,
slide,
do we have any other next
oh,
slide?
sorry,
Yes.
all right. So
This
sorry.
is actually a good one. I want to put in a little quip real quick. Subscribe to updates on our website. Go to our website. It's easy to click a box there to subscribe to updates. This will send you automatic emails like when new we have new technical releases that come out, new information added in that keeps you in the know. Then you're not having to actively seek out information from us. We just send it to you. So just go to our website, EBSA. .gov, I believe, easy enough to find, and then subscribe. And also, if you have any desire to have us present at any with any groups that you're helping, whether it's workers or whoever it is that may have an interest in this or this may be beneficial to them, please don't hesitate to ask. We're happy to speak to any groups that you need. And this is a great slide too. This
That's the
shows our
one. Yeah.
website.
Yeah, because you can get these publications. We'll just send them to you. You want a couple of these in your office? We'll send them out to you. You can just hand them to people like,
The
"Are
hard
you having a
copy.
problem with, your benefits? Here, read this." It's a nice, short, easy to read publication. It's in color. It has little cartoon characters. No, I'm just kidding. It's easy to read, right? It's easy to understand. So that's the point. And so, and our website is very good. When I first started, I would say, yeah, it needs some help. But now I'd say, no, it's a fantastic website, easy to navigate, easy to get information. You can put in, queries like, "Hey, I'm looking for this." And hopefully you can find it. So I don't know, Mary, I don't really want to go back and go over all that technical stuff. I don't think anybody needs to hear that. They can read it if they want.
You covered all the main stuff that
Okay.
people need to know. Does anybody have any questions? I
Well, we
know
encourage
everybody's
questions
dying to go
throughout.
watch a
So.
certain TV.
Oh, I was just gonna go watch some Ted Lasso. I wasn't gonna watch the Vice President. I know they're old, but there were so many of those I didn't get. I used to play soccer, so I kind of.
I do have just one general question. I say that you had Spanish. Is that the only language, or do you have other translations available to other language speakers?
So go ahead, Mary.
Go ahead. I was going to say, we can potentially get translations for pretty much any language from our national office. It just would take a little extra legwork
Sure,
potentially.
It's just a general question. I'm an English language learner paraeducator.
Oh, that's awesome. My mother-in-law is too. I love that.
Okay. So
You do a
it is. So I just thought I'd ask, because we are trying hard to work with people to have parity and explain that it's not a bad thing to have a mental illness.
Huge
Yeah,
issue.
and there's a lot of taboo in a lot of different cultures. I know that.
Yes. So,
Mhm.
if you can point them to a direction for help, it's great. So thank
Absolutely.
you.
That's amazing. I know I'd like to do more in the refugee community. I don't know if you have any connections there. We would really love to talk to them about mental health parity. I know we went to the Johnson County Mental Health Suicide Coalition meeting. I did several months ago, and we had some groups represented by the refugee community, and it was just really moving to hear their testimony, but it was sad to hear how little it's talked about and how it needs to be talked about. So if you need, or if you have connections, we're appreciative of those as well, because getting a foot in the door is always the hard part.
Absolutely, and particularly from my perspective, men have a hard time talking about their feelings and emotions, and they have a hard time admitting what they perceive as a weakness of saying they have mental health illness. And also, mental health illness manifests itself differently in men than in women, generally speaking. And so I've experienced that, throughout my life. And I'm one of those fearless people, and I'm an open book, and often I get that, Rob, TMI, back it up. I don't but point is, I think it's so important. I feel like I don't want anyone to feel like they don't know what to do or don't know where to go. What if it's too expensive? What if I can't, find a provider, mental health provider that is the right one for me? They're probably out there, and they may be hard to find, but it's worth finding that person. And we want to make sure that if you're entitled to these benefits getting paid, they get paid just equivalent with your medical benefits. That's the whole point. And so hopefully that came through.
Appreciate it greatly. Thanks, Vicki, for having the program.
Well, thank you very much, Rob and Mary Lynn, because this is very important. As I said, it's probably not the sexiest type of topic, but it's such a reality for so many of us in the different situations. So I thank you. Your information is helpful, and we will definitely keep your slideshow presentation, because it provides a wealth of information. So we are very happy.
And I could lie to you and say we have sexy presentations, Vicki. We do not. We don't have anything. It's just, about money.
The criminal ones might be kind of interesting.
Yeah, those get interesting. The Nancy Drew in me, that's where I kick in. The Nancy Drew in me, I would kick in on those investigations.
I mean, that big Enron case, that was a kind of fun, case. There's been probably docudramas about that. But it's all about, I just remember going to law school originally thinking, I just don't want to do tax or insurance. I just don't want to do that's all I do. But it's important, right? It's really important. I mean, it's money, it's your retirement, or it's your health insurance. And it's just a thing you need to learn about. And as much as you may not like it, I think it's boring, when you need it, then it's really important.
Then it's really important. Absolutely. I'm going to send you those slides right now, so that because tomorrow, it'll slip out of our brain.
and there's links in there, so we try to make it easy for you. But seriously, we appreciate the opportunity to speak with you guys. I wish I had the ability to promote this more, with some music or something, but I can't do that. So leave that up to you guys. But seriously, if you have people that need resources, we have publications. We have people that we can come and talk to different organizations. If you know what organizations, we're always looking for that opportunity. And usually people are trying to look for an excuse to get me out of the office. So like, please go talk to someone else.
Oh my God. Well, thank you very much. And thank you all who participated tonight. And we're